In this video, I'm going to demonstrate a canine ovariohysterectomy. We're using a canine cadaver today, and that's a suitable model. We won't have that much hemorrhage and we'll be able to see all the important structures. There are many different ways to perform ovariohysterectomy. This is one of several acceptable techniques. We're going to start by palpating the brim of the pubis and locating the umbilicus. The space between the umbilicus and the pubis, we're going to divide into 3. I have a marker here, and we're going to mark, just for the ease of identification, where the 3 separate sections are. So from here to there, we have 1, 2, 3. And for a canine ovariohysterectomy, our incision is going to span the length of this first cranial section. I'm going to use a 10-blade fingertip technique. I'm going to make an incision from the umbilicus. With my opposite hand, I'm spreading the tissue apart so that I can better assess how deep of an incision I'm making. I can use my blade to make my incision deeper. Alternatively, I can use my Metzenbaum scissors and thumb forceps to make my incision deeper. To do this, I cut a small hole in the subcutaneous tissue. I insert my Metzenbaums and gently using blunt dissection, establish a plane of dissection, then slide one blade of my scissors in and cut. And repeat. And my subcutaneous tissue incision should be just about as long as the incision of my skin. If I need to cut this way, instead of trying to cut like this, I can flip my scissors around, use my thumb and index finger, and cut like this. If I encounter any hemorrhage, those can usually be controlled by taking a small mosquito forceps and clamping the least amount of tissue possible, yet still clamping the bleeding, clamp and leave in place for about 3 to 5 minutes. You can come back and then release the clamp and the bleeding should have stopped. So I'm repeating this until I get down to the body wall. And once I'm at the body wall, I'm going to try to identify midline for the linea alba. It's a little hard to recognize in a canine cadaver specimen compared to a live specimen, but I believe I see the linea right here. Once I've identified it, what I'm going to do, using my thumb forceps, I'm going to pick the body wall up. I'm going to take my blade, and the reason for tenting this body wall up is so that it creates some space in between the body wall that I can't see and the organs inside the abdomen. I'm going to take my blade, I'm going to insert it by pushing it cranial with the blade facing up, and then I'll pull up. Now I have a small keyhole incision into the abdomen. Take my thumb forceps and I'll gently insert them, tent up the abdominal wall, and increase the length of my incision. Once the incision is wide enough that I can place my finger into the abdomen, I'll use my finger to palpate, see if there's anything adhered to the body wall, cranial and caudal, clear anything off. Once I'm convinced, I'll then use my thumb forceps again to tent up the body wall, extend my incision, and my incision should extend almost all the way to my skin incision. Take my clamp off here. Now I can either try to digitally find an ovarian, a uterine horn, or I can use my spay hook. To use a spay hook, I'm going to insert this along the body wall with the hook facing the body wall. As I get down to the dorsalmost part of the abdomen, I'm then going to turn it 180 degrees, drag it to midline, and then pull it up. So insert, hook is against the body wall, drag it all the way down, turn it 180 degrees. If you feel any resistance, you want to stop. So I have some tissue here, and I want to look at this tissue. Sometimes it's not entirely obvious if it's uterine tissue or not. I don't see any there, so we're going to try again. And I'm going to look closely at this. And there is a little bit of tissue here, and I'm not sure what that is. It could be uterine tissue. So what I'm going to do is I'm going to follow it cranial, because if it is uterine tissue, at the cranial extent of this horn should be an ovary. And that's usually easier to identify by palpation. So what I can feel is a bean-like structure, so it feels very suspicious for an ovary. And it's barely visible now, but I'm going to get a clamp ready, and I'm going to use a curved mosquito clamp. And I'm going to clamp the proper ligament of the ovary, and that's going to be our handle. The proper ligament of the ovary is it's tough connective tissue, and so it tends not to tear like ovarian tissue and like uterine tissue. So I have that clamped now. Just going to move the handles so that they're facing caudally. And I can pull it out a little bit further, and I can feel what feels like an ovary here. But I can't pull it out enough to really ligate my ovarian pedicle. So what I'm going to do is I'm going to break down the suspensory ligament. And the way that I'm going to do that is I'm going to apply some traction on this clamp caudally and ventrally, so sort of this direction. I'm going to take my finger, my opposite hand, and I'm going to slide it down the clamp. I'm going to find that tissue that feels taut, sort of like a guitar string. I'm going to follow it all the way down to the dorsal body wall. And where it meets that body wall, I'm going to use some pressure with my finger to rupture the suspensory ligament. As I do that, I'm pulling on this clamp, and you'll feel it give as you are successful in tearing through that suspensory ligament. The reason that we rupture the ligament as far dorsal as possible is because the ovarian vessels are farthest away from the suspensory ligament the more dorsal you go. so it's a safer area to rupture the ligament. You feel it give, and then you'll appreciate it actually coming out. Now, this is often an intimidating part of the surgery for many students. As long as you stay dorsal, the chance that you're going to rupture something that you shouldn't is very low. So now, you can see here, this is the right uterine horn. And although it's difficult to see, I can palpate the right ovary right here. So now what I'm going to do is I'm going to fan out this mesovarium. So that's the tissue that attaches to the suspensory ligament, the ovary, and the uterus, and the broad ligament. And that's where the ovarian vessels are in this fat, and they're not always visible. I'm going to fan that out. I'm going to look for a relatively avascular space in the mesovarium. And I'm going to take a clamp. I'm going to create a window. And I poke it through, and I open up the jaws a little bit. What I want to ligate is all the tissue between this window and the suspensory ligament. Now that I've made my window, I'm going to place some clamps. And I want to place the tissue at the tips of the clamp. I don't want to place it back here because these clamps don't always meet back towards the box. However, they always meet at the very tips. So place your tissue in the tips of the clamp. And there's several different techniques you can use using clamps. There are no clamp techniques. We're going to place 2 clamps. And as I place the clamps, I'm always going to palpate for that ovary. I don't want to clamp the ovary. And I want to make sure it's always going to be in the tissue that we're going to remove. So I have 2 clamps on there. Now I'm going to select some suture. And for most dogs, the ovarian pedicle, you're going to use a suture size that is 0, 2/0, and sometimes 3/0. For a larger dog like this, I'm selecting 0, and I'm selecting PDS, which is an absorbable monofilament. It has quite a bit of memory, so I'll stretch it out to relieve some of that memory. And I'm going to pass my suture through this window and around that tissue that I want to transect and ligate and transect. So what I'm going to do is I'm going to lift this up. I'm going to pass my needle driver through the fenestration. I'm going to pass my suture into the jaws of my needle holder. I'm going to pass it through, and I'm going to bring it around to the front here like this. So I'm around my tissue once. Now I could place a surgeon's knot, I could place a simple overhand knot, or I could place a miller's knot. I like the miller's knot, so I'm going to use a miller's knot. And what that means now is I'm going to pass it through one more time. And I give myself plenty of slack here. And I lay this loose end on my hand. I lay the loop on my hand. And this loose end I'm going to lay on my hand. So now I have 3 strands on my hand. I'm going to bring my thumb to my index finger. I'm going to wrap this around like that. Notice I don't have any suture in my thumb and finger, okay? I'm just doing that. I'm going to take this end and I'm going to pinch it in my thumb and finger. I'm going to bring it back through like that. Now I'm going to release everything. And this is the first throw of a miller's knot. I'm going to place this miller's knot below my clamp. So I'll turn my handles over my clamp. I'll grip each side of my suture and making sure I'm below my clamp, I'm going to tighten this. Alternatively, I could take this clamp off and I could place it in the crushed groove created by that clamp. That's another option. And I'm going to make this really tight. There's a lot of tissue, a lot of fat, and so it needs to cinch down so that it actually ligates the blood vessel in the center of all that fat. Okay. I complete this with 3 additional throws. Cut the ends. And we're going to double ligate this. So now what I'm going to do is I'm going to take this bottom clamp, I'm going to release it, I'm going to slide it up, and I'm going to put it above this clamp, making sure that I'm still below the ovary. So I'm going to palpate that ovary, make sure that I'm still below it. I'm going to pass it through that fenestration. Like that. My next ligature is going to be a transfixation ligature. So I'm loading up my needle on my needle holder. I'm going to hold these clamps up, and I'm looking for that crushed tissue that my clamp was on, and I'm going to pass this right through that crushed tissue. And I'm just going to place 1 throw here. And then I'm going to pass this long strand around. It has to go through our fenestration, like this. And I'm going to put 2 square knots. So now this ovarian pedicle is double ligated. It has an encircling miller's knot and a transfixation. The way this is clamped, now what I can do is I can cut between the clamps. And I want to be sure that I'm careful not to cut any tissue that's underneath, like the skin. You can use your thumb forceps to grasp this tissue as you unclamp it. What I don't want to do is I don't want to grab the tissue down here, because even though these are relatively atraumatic forceps, they can actually damage blood vessel walls. And so if I grab down here and it slipped out, it can cause bleeding. So I'm going to grip it up here where it's already ligated. So I'm going to grab a corner, unclamp. I'm going to follow it down. I don't see any bleeding. So I'm satisfied with that ovarian pedicle ligature. So now we have our uterine horn. And the next step is freeing this up from the broad ligament. So what you want to do is fan out this broad ligament and assess the size of the vessels. For young animals, the vessels are quite small, and you can simply tear this tissue, and it creates enough vasospasm that you don't get any significant bleeding. If the vessels are large, if the dog's in heat, then what you may need to do is ligate pedicles of tissue to ligate the vessels. To tear, what you can do is simply use your fingers to tear the tissue. And follow it down as far caudal as possible towards the uterine body and the cervix. There's a blood vessel. The uterine artery and vein runs parallel, and you don't want to cross that. So you want to, your dissection should be parallel to it as it goes down. We will be ligating those as they're closer to the ovarian, to the uterine body. As you get closer to the uterine body, you might find it easier to locate the left uterine horn and ligate the left ovarian pedicle . To find the left uterine horn, you can either use the right and follow it till you find the bifurcation, or you can use the spay hook. So here, we're coming up to the bifurcation. I can see this other tubular structure, and that is the left uterine horn. So I follow this back all the way to the left ovary. I have a clamp. I'm going to clamp that proper ligament. That's my handle, providing traction this direction. I slide my finger down. I find the guitar string. And with sustained pressure, as dorsal as possible, I rupture that suspensory ligament. Be patient. So now I have the ovary and the ovarian pedicle exposed enough where I can ligate them. I'm going to create a window. I can see the ovarian vessels in this area here, so I'm just going to go on the other side. I'm going to create that window. I'm going to clamp across this tissue. I'm going to palpate. I'm going to get my suture ready. I'm going to go through the window. Go below my clamps. I'm going to go around again for a miller's knot. I'm going to situate my suture below the clamps. And if you can put some space between your ligature and the clamp, it'll allow the tissue to gather easier and not fight the forces of the clamp, which is trying to keep the tissue fanned out in a flat pattern. If you're not able to do that, and you need to put your ligature right here, it's best to have somebody flash the clamp. And so this can be an assistant, or if you don't have an assistant, you can simply unclamp, and that allows the tissue to gather, and it's not You can use hand ties. You can use instrument ties. Either way, you want to make sure that you do not, as you're tying, jerk the strands of the suture. So you don't want to do this, because that can loosen up the throw that you just laid down. And if it's your first throw, then that can loosen up your whole knot, and you can have residual bleeding. So I removed the other clamp when I was flashing it. Now I'm going to replace it on the other side of this clamp, palpating the ovary, and there's plenty of room in between. And now I'm going to do a transfixation. So this ovarian pedicle has been double ligated. I can now transect between these two clamps. I can take my thumb forceps, grip just a corner of tissue right here, release my clamp, inspect the pedicle, make sure I don't see any hemorrhaging, and then release. I can tear the broad ligament like I did on the right side. As I come down towards the body of the uterus. There you can see the bifurcation. And if I palpate in there, I can feel the body of the uterus. And in some cases, you can feel the cervix. So you can see that as I pull this out, I'm not able to expose much of the body of the uterus. And so I have a choice to make here. And I can either extend the length of my skin incision and body wall incision to exteriorize more of the body of the uterus, or I can ligate and transect what I have exposed right now. With the latter, it does leave some uterine tissue with the dog, but that will have no consequence provided I removed all ovarian tissue. The exception to this is if the uterus is diseased and you suspect that there's a pyometra or hydrometra. I'm going to clamp, ligate, and transect the uterus where I have it exposed right here. And the way that I'm going to do that is I'm going to place two clamps. I'm going to use OHE PDS for my ligature. I'm going to pass my needle holder behind the uterus. I'm going to grip my suture and bring it across like this. I'm again going to use a Miller's knot. Situate my ligature below my clamps. And cinch it down. Three simple overhand throws on top of this. I'm going to further ligate this by doing what are called stick ligatures. So I'm going to release this clamp, apply it up here. I'm going to bring my needle, and my goal is to ligate the vessels that run along the lateral side of each side of the body. And so I'm going to pass my needle through this crush groove, through the uterine tissue, And I'm going to tie this. By doing it this way, I'm ligating the vessels on each side of the uterine body. And since it's a smaller amount of tissue, I don't have to use a miller's knot, so I'll just use square knots. The size suture that I could use, I'm using 0.0. I could also just as easily use 2/0. And again, this is PDS, which is a monofilament absorbable. You could use any monofilament absorbable suture for this. I'm going to do the same stick ligature on the opposite side to get this left-sided uterine artery and vein. And again, what I don't want to do is jerk up on this. I want to keep it nice and loose and lay down each throw so that it's not jerking up and loosening my previous throw. Now I can cut between my clamps. Grasp a portion of this tissue, unclamp, check for hemorrhage, and replace into the abdomen. And the ovary and the portion of the uterus that I removed, you can now put at the back of the table. If you were doing an ovariectomy, it would be the same procedure. However, you would ligate the uterine horn further up towards the ovary. Before I close, I want to check my pedicles. And the way to do that is to find the colon on the left side. And that's by palpation. And if you bring that out and reflect it towards midline and look down, the mesocolon actually retracts all other organs out of the way so that you can actually see the pedicle. So this is the descending colon. I'm retracting it towards the right. I tent open the body wall and I can see my ovarian pedicle. For the right side, if you can find the duodenum, that is your other landmark, and you can use the duodenum to retract organs out of the way so that you can see. How do you know when you got the duodenum? Because you look for the pancreas. So if I pull this out, this is pancreatic tissue here, so I know that this is duodenum. And I gently lift that over, pull it towards the opposite side, and I can see my ovarian pedicle. If I have any trouble doing this and I'm concerned about bleeding, I would simply extend my incision a little bit longer, extend your incision a little bit longer if you still can't see what you need to see. Now we're ready to close. And we're going to close the body wall with a monofilament absorbable suture, PDS. And for a dog this size, we're using 0.0 PDS. 2.0 PDS could be appropriate. 3.0 PDS, which is a smaller suture, would be inappropriate and would unlikely resist the tensile forces of this dog's abdominal wall. I'm going to close this in a simple interrupted pattern. I could also close it in a simple continuous pattern. However, in the early stages of your career, as you gain more experience, it's probably best to close the body wall in a simple interrupted pattern. So I'm locating the body wall, which I can see right here. Immediately deep to it is muscle, and I can identify that pretty easily. I can do the same over here. You can start at the cranial extent of the incision or the caudal. It doesn't matter a whole lot. Some people say you should start at the caudal extent. Ultimately, it doesn't really matter. I want to take good bites. And I want my bites to be relatively wide so that there's a decent amount of tissue that's being captured by. So I'm going to dissect this a little bit so you can see what I'm doing. You can do some dissection to see your body wall within reason. Keep in mind, the more dissection you do, the more dead space you create. So this is the body wall. That's the edge right here, and I'm going to take a bite that's back here. So about that much. And the holding layer of the body wall is the external rectal sheath, the external fascia, not the muscle. So you don't need to incorporate muscle into your closure. I do the same thing on the other side. I'm starting in the middle here so that you can see this relatively easily. Those are my 2 bites. They should be snug, but I don't need to white knuckle this and strangulate the tissue. So we want 2 square knots for each simple interrupted suture. When you cut these, you want to leave a small tag. If you cut it shorter, they sometimes tend to unravel. Spacing in between your sutures should be about 3 to 5 millimeters. I'm finished suturing the body wall with interrupted sutures of OHE PDS. I'm happy with the spacing, and when I palpate this, I don't feel any defects in the body wall. One of the common mistakes that veterinarians make when they're first performing this procedure is, instead of passing their needle through the body wall, they pass it through the subcutaneous tissue. So make sure that you can see the body wall and that you are actually passing your needle through the body wall, because that is what's holding the abdominal contents within the abdomen. Next, I'm going to do my subcutaneous layer. And I'm also using a monofilament absorbable suture. This is 2.0 PDS. You could also use 3.0 PDS. And I'm going to do a continuous pattern. And because there's not a lot of subcutaneous tissue here, I'm going to bury my knot. So what that means is I'm going to start in the deep tissue at the cranial extent of my incision. I'm going to come out rather superficial. Now I'm going to go to the opposite side. And what I like to do is flip my hand around like this so that my needle goes into that subcutaneous tissue almost parallel to the skin. And then I can flip it around. And that needle insertion helps me oppose the tissue relatively well, the skin edges specifically. So now I'm going to tie this. And this is not a holding layer, so we're not relying on this to hold organs in place or anything like that. It's merely to oppose tissue. So 2 or 3 knots is plenty. Now, because I buried my knot, this strand is coming out deep. So what that means is I need to start deep. So I'm going to start deep, come out superficial. I'm going to come over on this side now, go in superficial, and come out relatively deep. How close you come out and enter to the skin will dictate how close you oppose the skin. So in a relatively skinny animal, you can actually oppose skin with this layer. Sometimes I'll leave some slack in my loops. It kind of helps me visualize the tissue a little bit better, or what my spacing is, things like that. Then I can come back, tighten it up a little bit. Now, if I wanted to oppose the skin on this layer, I would come out closer to the skin edge. But I'm going to put skin sutures in for demonstration, so I don't need to oppose the skin. If I had a thicker layer of subcutaneous tissue, if this were an obese animal, I would take an occasional bite of the body wall to tack down the tissue. So I'd take just a bite down here. Then after doing that, continue. Now to end the suture, I need to think about that now and not at the very end So I'm coming near the end and I want to bury this knot. So what I'm going to do is I'm going to take this loop that's deep and I'm going to pull it out like this. I'm going to hold that off to the side. I'm going to come in superficial to deep, but instead of advancing it caudal like I have been doing, I'm actually going to come out more cranial, back towards this loop that I'm holding. And now this is coming out deep. So now I have this strand that's deep and this loop that's deep. And if I tie the two, my knot should be deep. So a simple square knot. And 2 square knots is plenty. You do not need a surgeon's knot. In this layer, surgeon's knot is infrequently needed. It's appropriate when you have a lot of tension in the tissue that you're trying to either ligate or oppose. And we just don't have that kind of tension in the subcutaneous tissue. Skin sutures, I'm going to use a nylon. This is Ethylon. And you could use 3/0 nylon or 4/0 nylon. And I could either do interrupted sutures, or I could do cruciates or a forward interlocking. And you want to cut these a little bit long so that whoever has to remove them can grip them and tent it up a little bit. So that's an interrupted. We'll do a cruciate. You'll notice that I'm not actually gripping the skin with my forceps. I'm just using it to help push. If I can minimize the amount of gripping on the skin edges, I'm minimizing the trauma to the skin edge. And I want to see a little bit of daylight underneath the loops, whether it's a simple interrupted or a cruciate. My first simple interrupted might be a little bit tight. This one's a little bit better. Do a short forward interlocking here. When I want to end this, I'll come back through, bigger bite, that. Back through again, create a loop and a strand, and I'll tie these two together. And that is a canine ovarian hysterectomy.